Hi, this is E. David Crawford, Editor-in-Chief of Grand Rounds in Urology. We're fortunate to have Dr. Jerry Andriole join us today to present a talk that he was invited to give at the Society of Urological Oncology last week in honor of Dr. Richard Williams. And Jerry's talk focuses on what we've learned in directions and early detection of prostate cancer. It is really a game changer. And so Jerry, thanks very much for spending time to give this talk to our group.
Well, thank you, Dave, for the very kind introduction. It is really heartwarming to be the Richard Williams Prize winner. I knew Dick very well, and he was a mentor to me over the years. And I really feel that this is one of the most singular honors I've ever received. Today, I'd like to talk about some considerations to improve screening for prostate cancer. These are my disclosures. As way of an outline, I'm first going to just review some of the guidelines for prostate cancer screening and early detection from the AUA, the EAU, and the NCCN. I'm going to talk about rates of PSA testing and propose some concepts to improve screening for prostate cancer. Now, everyone's familiar with the AUA early detection guidelines that were last updated in 2018. And basically, they strongly recommend shared decision-making for men between the ages of 55 and 69. And they recommend a 2-year interval of screening. The AUA does not recommend routine screening for men over the age of 70, and particularly if they have a life expectancy of less than 10 to 15 years. Now, the NCCN guidelines are somewhat similar, but they recommend starting earlier in life to have a conversation about the risks and benefits and to obtain an early in life baseline PSA, because that can be used to stratify the intensity and the time at which screening should be started. And a lot of this is this recommendation is based on, I think, a very important study by Hans Lilja and colleagues that looked at the median PSA values for men in the fourth decade of life. And basically that showed that those men should have a very low PSA in the 0.5 to 0.7 range, and that PSAs above that should be considered worrisome for the future risk of prostate cancer. And here's just a schematic diagram showing the distribution of PSAs in this early in life population and their outcomes in terms of the development of clinically significant and other prostate cancers. Now, the EAU recommendations are shown here. Again, they stratify the frequency of testing on the basis of the PSA. So if it's very low, repeat in 5 years. If it's intermediate, repeat in 2 to 4 years. If it's high, and in their cut point, they recommend 0.3, proceed with other features. The thing that surprises me is over here for the group of men between the ages of 60 and 70, for a PSA of less than 1, they recommend stopping PSA testing. And I think on the surface of it, that sounds pretty good. And it was a finding from the Hans Lilja study. But I think for American urologists, and particularly for men who have a very long life expectancy, I personally would reflex to another test such as the 4K score, because that can really differentiate for men over the age of 60 whether or not they have a significant future risk of prostate cancer. I will also just say that the Europeans are testing the validity of an early in life PSA, what's referred to as the PROBASE study, in which they randomize patients to get started with PSA screening between the ages of 40 and 45 versus at the age of 50. And you can see from the young men arm, the prostate cancer detection rates thus far have been relatively low at 0.19%. But this study obviously will take many years to mature. Okay, so what can we do now to improve our screening efforts for prostate cancer? And the first thing I would like to point out is that we really have to do a better job identifying which men are at an above average risk for prostate cancer. Now, here are some of the things that urologists can use to talk to their patients about his individual risk for prostate cancer. And I think urologists have done a very good job looking at family history, African ancestry, early in life PSA, the selective use of reflex tests, as we mentioned above, various nomograms and risk calculators. But I think where we can really improve our discussions with our patients is to look at some of the hereditary risk for prostate cancer, either in the form of high penetrance genes such as BRCA mutations, or more commonly in these polygenomic risk scores. And I think there is a little bit of confusion in the lay public and among certain practitioners, the differences in the genetic risks that we've been talking about over the years. There are somatic DNA non-heritable risks. And an example of this is if you order a Decipher, an Oncotype, or a Prolaris test based off a biopsy that showed prostate cancer. That's a somatic mutation. The heritable mutations are either the highly penetrant mutations, such as a BRCA abnormality, or these low penetrant germline SNP abnormalities. And if you were to just compare the heritable risk factors that we have, well, there's family history, patient-reported family history. There are these high genomic risk scores, and that comes from the SNP data. And you can see the proportion of patients who would be placed at higher risk based on that. And you can see that these high penetrance genes, well, very risky for the man's future risk of prostate cancer, actually only comprise a relatively small portion of the entire range of heritable risk for prostate cancer. Now, I'd like to turn your attention over here to this final column. You know, if a man said that he had a positive family history for prostate cancer, his incidence and his mortality of prostate cancer are significantly increased, and you can see that here. If he has a high genomic risk score, again, his incidence of prostate cancer and his risk for mortality go up significantly. But here's a valuable thing. If a man says his family history for prostate cancer is negative, it really does not significantly reduce his incidence or mortality risk from prostate cancer. But on the other hand, if he had a low genomic risk score, that significantly reduces his chance of having prostate cancer by slightly over 50%. And it reduces his chance of dying of prostate cancer by 2/3. So a low genomic risk score is sort of a high negative predictive value, and that's very important for patients. Now, the risk score that we have available to us right now in the United States is the PROMPT risk score, and this is a cheek swab. And I first started looking at this test while I was principal investigator of the REDUCE chemo prevention trial. And in that trial, because all of the men were required to have an elevated PSA, the average risk for prostate cancer was 23%, compared to the average risk for men in the United States is about 17%. But notice how the polygenomic risk score stretched out an individual man's risk for prostate cancer. It didn't dichotomize it into low risk or high risk. It really spaced it out quite dramatically. And in the REDUCE trial, if PSA screening was applied to the 25% of men who were at highest risk of prostate cancer, we would have found 55% of the significant prostate cancers overall. And had we foregone screening and biopsy in the 25% of men who were in the lowest risk quartile, we would have missed only 8% of the intermediate and high risk prostate cancers. We also looked at the prompt score in the PLCO trial, and you can see that for whatever the PSA cut point you were looking at, the polygenomic risk score quartile significantly increased the finding of a positive biopsy in these matched cohorts. We also looked at the prompt test in the prostate cancer prevention trial, and this is actually pretty fascinating to me. So these are the for-cause biopsy results in the non-finasteride arm. So if you took the 11,000 patients who were getting annual PSA testing and you looked at only the for-cause biopsy, you would have found 20% of all the cancers and about a third of the higher grade cancers. If you said, oh, geez, I don't want to screen everybody, I only want to screen men who reported a positive family history, well, okay, you would have screened 2,000 patients, but along the way, you would have only found 12% of all the cancers and 17% of the significant cancers. If you said, okay, wait a minute, I'm only going to look at men whose baseline PSA was over 1 or over 1.5, you could see the number of patients you would have screened. You can see the proportion of cancers you would have detected, again, not very high. On the other hand, if you said, I'm only going to screen the men who had the highest risk, polygenomic risk score from the prompt test, you would have only screened 4,300 or 4,400 of these patients. You would have found 28% of all the cancers, but most critically, you would have found 49% of the significant cancers. So you can see how knowledge of the prompt score really can focus your screening efforts on the patient who need to be screened. Here are some data from Kareem Kader. This is a personal communication from a study that he's been doing. And you can see that the baseline risk for prostate cancer depends on a man's age and his family history. And you can see the area under the curves associated with using those parameters to predict prostate cancer. You can see what happens if you add PSA, if you added the prompt score, and if you add both the PSA and the prompt score, you significantly increase the area under the curve, particularly to find high risk and significant prostate cancer. Again, personal communication from Kareem and also data from the REDUCE trial shows that a low polygenomic risk score really has a high 94 to 96% negative predictive value for significant prostate cancer. So that's something I think urologists and potentially even primary care physicians should incorporate into their risk assessment for an individual patient. Another thing that I think is important is that patients and primary care physicians need a simple message on PSA. Well, why are they confused? Well, the U.S. Preventive Services Task Force first gave screening a D recommendation. Now it's a C. The urological community has proposed multiple PSA cut points that have been studied and reported in a variety of ways. We looked at 2.5 at WashU. The Europeans like 3. The cut point of 4 is what we used in the PLCO screening trial. And there are age-adjusted PSA cut points, race-adjusted PSA cut points. It's a pretty confusing topic. Now, a possible solution to this is to try to simplify things and consider telling our primary care colleagues that a PSA of over 1 or 1.5 is the threshold for referral to a urologist, and then let the urologist take it from there. And this is an idea that was first promulgated by David Crawford a couple of years ago. And I think we really should look at it pretty carefully. So this idea that a PSA of less than 1 is not worrisome for prostate cancer first started in the PLCO cancer trial. Robert Grubb was a faculty member at WashU, and Dave Crawford also is an important part of the PLCO trial. So we reported in 2008 that if you had a PSA of less than 1 at baseline, your 10-year risk of aggressive prostate cancer was only 0.5%. A couple of years later, from the ERSPC, they reported that if you screened patients whose PSA was less than 1 at baseline, you would have to screen 24,600 men over 13 years. You would identify 724 prostate cancers. You would treat those prostate cancers. And in the end, you would prevent exactly 1 death from prostate cancer. So really not an efficient use of screening. And again, we talked about Lilja's finding associated with a low baseline PSA implying prostate cancer after the age of 60. But this all started in the PLCO cancer screening trial. I'm also happy to report that just last year, other investigators looked at a baseline PSA in PLCO, and you can see a baseline PSA of less than 1, 12 and a half years later, had a very, very low occurrence rate of clinically significant prostate cancer. Again, I think the data are incontrovertible that these very low PSAs can really reduce the frequency and the intensity by which we screen men for prostate cancer. Now, here are some data from David Crawford from the Henry Ford HMO looking at the ROC curve, and you can see that the optimal cut point, the maximum sensitivity and specificity was a PSA cut point of 1.5 and an estimated area under the curve of 0.87, which is really, really quite high. And this cut point of 1.5 works well for urologists in addition to the screening implications for prostate cancer, but it also has implications for the patient's clinical outcomes from BPH, as it's been shown that urinary retention and the need for surgery is highest in men who have significant LUTs and a PSA over 1.5. So from a urologist point of view, these are the patients we should see both for BPH concerns and also for their risk for prostate cancer. Third thing I think we should do is identify patients with clinically significant prostate cancer earlier in life. And why do I say that? You know, if you look at the best screening trial, some of the best results from the ERSPC, there's really only a 20 to 30% relative risk reduction for the entire population. If you drill down, you say, gee, we got to do a protocol analysis only of the patients who truly follow the protocol. Well, then you could get a 40 to 45% relative risk reduction. Well, turn that around, and that says, gee, somewhere between 55 and 80% of men destined to die of prostate cancer still die of prostate cancer, even though they're getting screened. So we've got to do better than that. And so we already talked about lowering the PSA cut point for referral, but I also think we need to do a better biopsy. And I'd like to say that if a biopsy is warranted, you've got to do a quality biopsy. In my practice, I now avoid conventional office-based random transfecal biopsy. This type of biopsy, 12 cores, misses about half the cancers, and the cancers it discovers are mischaracterized very, very frequently. So it underestimates the grade or the size of the cancer. I think image-guided biopsy, either with microultrasound and or MRI, is the preferred type of biopsy. If neither of these are available to the practitioner for whatever reason, then a transperineal biopsy is the way to go. MRI has been around now for 6 or 7 years. We're all familiar with the PIRADS classification and the implications of a high PIRADS score in detecting prostate cancer. The problem is that the negative predictive value of an MRI that does not show prostate cancer isn't high enough to avoid biopsy. And so you can see in some of these studies, the negative predictive value is as low as 74%. If you look at a variety of different institutional studies, it's somewhere between 80 and 90% reliability to determine that the patient with a negative MRI should not have a biopsy. And that's just not high enough. Other problem with MRI is that there's a high variability of interpretation among radiologists. This is a study we did at WashU. There's a similar study reported recently from Stanford showing that even highly experienced radiologists looking at high quality MRI scans have a variable negative predictive value. This individual is only 77%. This individual had 100% negative predictive value. So there's just a lot of variation out there in terms of MRI. One solution to this problem that I like a lot is micro ultrasound. Micro ultrasound operates at 29 megahertz in comparison to a conventional ultrasound that only operates at 6 to 9 megahertz. This higher megahertz of screening allows for a 300% improvement in resolution down to 70 microns. This enables real-time targeting of biopsies, and this is controlled by the urologist. There's no radiologist between you and the patient. You can see a lot of details on these micro ultrasound. There's a patient who previously had a biopsy of the prostate, and you can see his biopsy core sites. There are recognizable patterns of aggressive prostate cancer, such as the starry sky and the mixed echogenicity. There is a Primus classification that's very analogous to the PIRAD classification. And this really doesn't take very long for urologists to become familiar with. The estimated learning curve is only between 15 and 40 cases. These biopsies can be done either transrectally or transperineally, and they can be done with or without MRI fusion. Now, this has been, the Primus classification I refer to has been validated in a number of studies. You can see a very similar set of findings for patients with the highest Primus scores, as I showed you before, for the highest PIRADS abnormalities associated with MRI. Microultrasound, systematic and targeted biopsies is better than systematic biopsies alone in terms of finding clinically significant prostate cancer. In an individual institutional study, microultrasound found 13 clinically significant prostate cancers that would have been missed by MRI. And in a multi-institutional study, comparing multiparametric MRI to microultrasound, the p-value for non-inferiority was quite significant. So microultrasound is not inferior to MRI. And although the study wasn't designed for it, if you did a p-value calculation, you had a pretty significant p-value that it may in fact be better, more sensitive than MRI to detect prostate cancer. I like this slide here because the dark blue colors are the significant prostate cancers that you want to find. And so if you do non-targeted biopsies on patients, here's how many of the significant cancers you find. If you did MRI targeted, you find some more. If you did microultrasound targeted, you find more than that. If you combine non-targeted with MRI, here's what you get. If you combine non-targeted with microultrasound, here's what you get. But if you do all the biopsies, non-targeted, MRI targeted, and microultrasound targeted, you're going to find the highest amount of clinically significant cancers in the population. So I think that's really a high quality biopsy to do it that way. Another thing we need to do as urologists is reduce unnecessary initial and repeat prostate biopsies. And you can see from the NCCN guidelines, the ways to do that are to insert MRI and or biomarkers before proceeding to biopsy for patients who have an abnormal PSA. These are the biomarkers that NCCN recommends for consideration: free PSA, XODX, PHI, OPCO 4K, PCA3, and select MDX. And you can see some are blood-based and some are urinary-based. We looked at 4K and PLCO, and we determined that that could eliminate 30% of the unnecessary biopsies and wouldn't have missed a single clinically significant cancer if we set the threshold for biopsy at more than 5% risk for clinically significant cancer. There are a number of conceptual things going on in the urological community to determine whether a biomarker should be used first or an MRI should be used first. And then depending on the result of the initial test, should you also then reflex to the opposite test? So if you started with a marker and it's suspicious, should you then go to an MRI? If you started with an MRI, should you then proceed to a marker? We did some work in collaboration with a couple of other institutions looking at the combination of MRI and the 4K score. So if we did the 4K score first, we had a 41% risk of 41% fewer biopsies. If we did the MRI first, we had 37% fewer biopsies, but the cost was much higher because of the higher cost of the MRIs. And you can see that a strategy of doing the 4K first would have missed fewer cancers than the strategy of proceeding with the MRI first. Here's another study from UCSF that looked at the 4K score, the urinary exosome test, and MRI, and they considered 8 different algorithms to do these tests. And you can see that the 4K score alone, followed then by an MRI, would have missed the relatively small number of high-grade cancers, and you would have avoided the expensive MRI in up to about 40% of the cases. But as a urologic community, we need to do more studies like this to better define which biomarkers we should evaluate our patients with and how we should reflex from that to an MRI, a micro-ultrasound, or straight to a biopsy. And the other thing I want to just mention before leaving the topic of image-guided biopsy is let's keep an eye on MRI and PSMA PET to find prostate cancers within the prostate. In some preliminary studies, gallium PSMA PET MRI was superior to MRI in clarifying the location, the size, and the extent of prostate cancers. And as we now have better PSMA PET scans, whether it's PYLARIFY or Blue Earth's radio hybrid PSMA PET scan, I think this is an area we're going to need to exploit further as well. If you don't have any image findings and you want to do a good biopsy, I agree it's time for Trexit, that we got to get rid of transrectal biopsies, and a transperineal biopsy is a good way to go. You can do a grid-guided biopsy, and these are older results showing very high prostate cancer detection rates, even for patients who had up to 10 previous sets of transrectal biopsies of the prostate. If you don't want to do a template-guided biopsy, you can do a hand-done biopsy using a variety of transperineal devices. In our practice, these 10-sector biopsies found a pretty significant proportion of prostate cancer and clinically significant prostate cancer, depending on whether the MRI status was not known or the MRI was known, but it was known to be not suspicious for cancer. This was an interesting study showing that a transperineal biopsy was almost as informative as a suspicious MRI to predict upgrading of patients who were under active surveillance. So these transperineal biopsies, whether template guided or hand guided, really do have a high probability of accurately clarifying what's going on in the prostate. So finally, I think we should look at enhanced risk stratification of the tumor. And we actually have been doing a pretty good job as a urological community, sending our low and intermediate Gleason tumors off for testing for somatic abnormalities, either by the Decipher, the Oncotype, the Prolaris, or even the ProMark tests. The thing is that these test results don't often make that much of a difference. So if you looked at favorable risk patients, those are patients with Gleason scores of 6, you evaluated them with these markers, well, pretty much you would have one additional patient would undergo active surveillance for every 9 men you tested. At the opposite end, if you tested unfavorable risk patients with these, you would find one patient out of 25 who seemingly could undergo active surveillance instead of active therapy. So they don't really make that much of a difference in how we're treating the patients, but it's a start. One of the real weaknesses of these tests is shown here. And so if you had conceptually 2 patients, one who had only Gleason grade group 1 and another patient who had Gleason grade group 1, but he also had other foci of more aggressive cancer. And let's say your biopsy only hit the Gleason grade group 1 cancer in those prostates. The scores, whether it's Prolaris, Decipher, or Oncotype, overlapped. So it doesn't, these biopsy results don't necessarily tell you what's going on in the prostate. They can only tell you what's going on in the tumor that you hit, type thing. But better tests are out there and likely will be coming to the forefront soon. Because of some of these limitations, my personal use of these tests is relatively infrequent, and I restrict that to for the most part, to patients who have high volume Gleason 6 disease or low volume Gleason 3+4 disease. That's probably where these tests would be most useful. They're really not useful for very high and very low volume and low risk prostate cancers. So in summary, I would say as a urologic community, we need to aggressively screen men who need to be screened. Got to look at family history, race, early in life PSA, and their polygenomic risk score. We should recommend an early PSA cut point for referral, and I like Dr. Crawford's idea of about 1.5. An abnormal PSA should not result in an automatic biopsy. We should reflex to imaging, whether it's MRI, microultrasound, and/or biomarkers. And our challenge is to figure out the most efficient way to use those tests. Whenever we decide to do a biopsy, we should do a quality biopsy. I think we should avoid these office-based random transfecal biopsies. And lastly, of course, if we do detect prostate cancer, we should consider both patient and tumor factors before recommending treatment. So once again, thank you very much for the very singular honor of winning the Richard Williams Prostate Cancer Research Prize and having the opportunity to deliver this talk. Thank you very, very much.
Jerry, thank you. Thank you so much. I know Dick Williams would be pleased and impressed with that presentation you just made. I guess in the last 3 decades, I've had the opportunity to listen to a lot of your talks on early detection and see the evolution to where it is right now. You and I worked together in the PLCO a long time ago, and we're starting to see some data come out of there. I appreciate your call out of our 1.5. It is catching on, and I think it is a nice cut point, and you had some good data there to support it. A couple of questions, and I guess that the first one is this polygenic risk score that Kareem Kader and the group has worked on is very interesting. Yet it does not seem that it's caught on a lot yet. What's the drawback? What's the downside? Is it just education? Is it availability? Is it cost, or what?
Well, that's a great question. I just think the urological community at large is not aware of it. The test itself is not very expensive, and actually it's available as a direct-to-consumer test. So it's a cheek swab, and a patient could choose to order it himself by going to the company's webpage. I think it's a very powerful way of optimizing our knowledge of an individual man's risk for prostate cancer. And we do need to get the message out. That's why I appreciate grand rounds in urology, because all urologists want to do a better job, and this is one tool that should be able to help them.
So how does that integrate? I know you had a couple of slides. How does the polygenic risk score integrate with PSA? Do you still believe we should throw the big net out and let the little fish out and catch the big ones and help determine which ones need to be biopsied or whatever? So where does PSA fit in here?
Well, no matter what your PSA is, if you then knew your polygenomic risk score, it increases the probability that you harbor cancer. So if you looked at men with a PSA of 4, let's say using historic data, about 20 to 25% of those men had prostate cancer. But if you said his PSA was 4 and his polygenomic risk score was higher than that, then his chance of having prostate cancer is more like 35, 40%.
What about a guy that has a PSA of less than 1.5? Let's start out right there. Does he need a polygenic risk score?
Yes. Yeah. So that's the perfect data from the PCPT trial. You could segregate him into a low or high risk category on the basis of his polygenomic risk score, because there are certainly men who have low PSAs who are yet at high risk for prostate cancer, and you could uncover them by looking at their polygenomic risk score.
But nevertheless, our PLCO data and other data and Henry Ford data would say that if you have a PSA of less than 1.5, your risk of developing prostate cancer in 10 years is significant as near 0.
Well, remember, if you do the polygenomic risk score, only 20 to 25% of the patients are going to fall out into the high risk category. So you're right, 75% of those patients, the majority or 80%, are in fact at very low risk for prostate cancer. But if you could uncover the 20 to 25% who are at high risk, you're not going to miss it. You'll just miss fewer and fewer people.
Yeah, there's no question. You touched on multiparametric MRI, that there's some value to it. I think we've been sort of buried with all this multiparametric MRI, and we need to sort of dig out of it. And I think you showed that there are some issues with it. There's some upsides and downsides. One of the things that you mentioned that I liked was using molecular markers as a way to direct who would get the multiparametric MRI or just go on to biopsies. And I don't know if you're aware of it. We had a publication last year with Yale Barents from looking at about 500 men from the Netherlands, and then looking at using select MDX as the first test, and if that's abnormal, then go to multiparametric MRI. It was basically a 4-arm study. I think that's something that is important for the future.
Oh, absolutely. I mean, we need to look at all of these biomarkers separately as individual tests, but also with multiple use of those markers, plus or minus MRI, to figure out the most optimal way to do it.
And I think one of the things you touched on too is very interesting, is when everybody talks about, we're very proud that we put 60% of our patients on active surveillance and so forth and so on. You've heard me say, we don't want to find patients for active surveillance. We want to find people that need to be treated in significant cancers. You talked about grade group 1 and 2 and 3, and that prostate that had a low grade and higher grade cancer in it. And it's interesting. You said it didn't differentiate it, but my thought was, like Oncotype and others have looked at common genetic abnormalities or genes between the low group and the high group, and that's where they get that pick it up and have some differentiation. And I think they've had some recent update over 10 years now with outcomes.
Well, I'd like to see that. I mean, that was one study. It didn't have that many patients in it. And yeah, I'm aware of the fact that there are stromal genes that theoretically are everywhere within the prostate that can predict whether the neighboring prostate cancer is going to be aggressive or not.
Mhm.
So yeah, I'd love to see those data, get out there.
So let's just finish up with a moonshot, Jerry. If you put all our resources together or whatever, where should we be 5 years from today with early detection of prostate cancer? What do you see in your crystal ball? What can we make happen?
Oh boy, I would like to have a really good imaging test so that biopsies are no longer necessary. And maybe these PSMA PET MRIs are going to be the next quantum step in that direction. So I think if there was an imaging to detect prostate cancer or more sensitive urinary markers, that's probably going to make the biggest difference in identifying prostate cancer.
We're not going to do PSMA PETs or that markers on the general population. So how do we figure that in?
You're going to see who's at high risk, who warrants that type of imaging test. And so we're going to replace all the men now, the million men a year who get a biopsy. Well, we're not going to need to do 1 million biopsies because we're going to have better risk classification. And instead of doing biopsies, we'll do, I hope, some sort of molecular test and or imaging test that would allow us to be confident that cancer or significant cancer is present or not. And we're going to proceed to therapy without the need for biopsies.
Yeah, you and I have disagreed on many things over the years, and constructively. It's been fun, but I agree with you that we're at the point now with imaging, and we're seeing this in the more imaging we do, where lesions light up in the prostate, and that they're not. There's not any sort of false negatives to speak of. And I think that's it. I agree. I think we're going to have some urine tests that we do or something that tells us who to go after. And I think we're going to learn a lot from that too. The other thing, what do you think about this? Is I have told the residents over the years and fellows, I don't think we're going to be doing all these radical prostatectomies and radiation in 5 years from now. What do you think about that? I mean, you don't need your prostate, and there's so many ways to ablate it and attack it. Now we have, focal therapy is just in the beginning. But what are your thoughts about that?
I agree completely. I think we'll look back at 30 to 40 years of significant numbers of radical prostatectomy and say, what were we thinking? Type thing. That focal ablation and other targeted systemic treatments such as lutetium or something tagged may eradicate prostate cancer just as well as radical prostatectomy.
And I think, they were already working on more than one ligand that you can go after. The other thing you brought up that I think that's not out there in the general public right now enough is micro ultrasound. And you did a very nice job of summarizing it. So where do you think that's going to be? Is that going to sort of replace MRI, supplement it? Where do you see happening in the next 5 years? With
we'll find out. I don't recall if I mentioned that we're doing a 3-arm study now, basically comparing micro ultrasound to MRI to the combination, and we'll find out whether it's as good or better than MRI, and whether we may be able to omit MRI, because remember, that's a very expensive test. Micro ultrasound is under the control of a urologist. A micro ultrasound targeted biopsy is more accurate than a fusion targeted biopsy. No matter how good the software is in your UroNav or Artemis platform, you're going to do it's not perfect, and you'll do a better job targeting lesions for biopsy and targeting lesions for treatment.
What about the learning curve? What about the learning curve with micro ultrasound?
It's said to be between 15 and 40 cases. I didn't have time to put that slide in there, but there's a nice web-based tool for practitioners to look at online, and then in real time, as you begin to do these studies, you'll get feedback from ExactView on how good you're doing, and compare that actually to machine learning and some artificial intelligence platforms.
We've been doing micro ultrasound now for over 2 years, and I'm impressed with it, just like you are. I just had a case last week that we were going to MRI targeted biopsy. I did your biopsies, systemic biopsies, 12 of them, systematic rather, and then did target with the lesion on MRI, and then I saw another lesion on micro ultrasound, more towards the apex. I labeled those, and guess what? The one that I saw on micro ultrasound came back as 437. All the other biopsies were negative, and we're seeing that a lot. I think that, yeah, you're right. There's a learning curve, but the ExactView folks have done a really nice job of putting together an educational program, and I see that sort of as the future also 5 years from now. Go ahead.
No, I agree. I think it's going to put urologists back in control of what's going on in the prostate. I love my radiological colleagues, but I think they're going to be unnecessary in the future.
Yeah, the only thing I sort of disagree with you about is transrectal versus transperineal. As you know, at the SUO, there was a very nice debate about that, and putting it side by side in reality. And I think what was learned is that doing better biopsies, doing more targeted ones, doing antibiotic prophylaxis better, that the difference isn't huge, and everybody can't do transperineal biopsies, and it's difficult. So I don't think we need to completely trash them. I think that it's preferable, but not always necessary. And well, I try to do it, but we still do some in the clinic. Jerry, I know you're very busy. Thanks so much for being with us. Those in the audience are not aware of that. You've left Washington University in St. Louis, as you always say.
Correct.
And it's been a real loss for them to have you go. And now Jerry is in Washington, D.C. area with the Johns Hopkins Hospital affiliate there. And what a gain for them. So we'll stay in touch, and thanks very much for your time. We really appreciate it, Jerry.
Most definitely, David. Thank you for your friendship and mentorship over the years. It's been a lot of fun, even though PLCO was a little bit painful for a while.
Yeah, well, we drug through it, and you know what? I've said it a long time ago, and it's going to take time. We're not going to see the results in 10 years, and we're starting to see some of that. Thank you, and we'll see you around, and have a great holiday.
Thank you. You too, David. Bye-bye now.
Bye.